Thank you very much for the invitation. Thank you for the kind introduction, and I'm delighted to be back in London today to present this to you. So first of all, I'd like to share with you a few facts about marathons. Marathon running is very popular, so over 2 million people per year in Europe run in marathon races, and this is a number increasing by 5% every year. We're privileged in London to host the London Marathon, which is the largest mass participation event in the UK, and actually third largest in the world, and it's big business. It attracts over £50 million raised for charitable organisations every year, breaking Guinness World Records. And the vast majority of these participants, they're not elite athletes, but they're self-motivated runners achieving a personal challenge. And in that respect, they serve as quite an attractive natural model or natural experiment that we can study. Now, what can we study? What hypotheses can we test? Well, I'd like to show you some data from Dr. Gatti and Dr. Chandra, Dr. Gatti, who you've heard from earlier today, who looked at a population of athletes, over 1,000, and when scrutinising their echocardiographic data, saw that in 18.3% there was evidence of high amount of trabeculation. Now, they postulated that perhaps this is part of athletic remodelling in line with left ventricular hypertrophy or left ventricular end diastolic dimensions. Perhaps this is a sort of morphological adaptation change, but perhaps in a small minority, this may be unmasking of an underlying cardiomyopathy. Dr. Gatti went further again and should be commended for what I now appreciate to be what must have been a very challenging and difficult study to continue follow-up longitudinally. So she took pregnant women and investigated them with echocardiography at the first trimester of pregnancy, when they were heavily pregnant in the third trimester of pregnancy, and also postpartum, and found a 25% increase in left ventricular trabeculation indices by echocardiography that regressed postpartum. Now, being pregnant and exercising, athleticism, or running a marathon for the first time, they're not exactly the same stimulus. So we designed a study to look at novice marathon runners and look to see what exercise-induced cardiac remodeling potential or phenotypes we would find. So we took these individuals when they achieved their ballot places, often around October the 11th in 2016, and we retested them after they'd run their marathon, the earliest opportunity being the 1st of May and some of the subsequent weekends. We took these individuals, we brought them in to Bart's Heart Centre over a weekend where we had access to all the imaging tools that we could use and utilise, and that included cardiac MRI and blood testing. We performed echocardiography on these individuals, ECG, took their blood pressures, and performed a sort of combined cardiopulmonary exercise test on a tilting exercise bike, with also exercise echo, as demonstrated in this film. Now, in this kind of model, we were able on a weekend to investigate 28 subjects and required about 20 staff running all these individual protocols to do this in a very efficient way and test these individuals over just sort of three consecutive weekends. And our population was drawn, as you like, so from all 250,000 individuals who are interested in applying for the marathon. Of course, there are only a certain amount of ballot places that will be allocated, and those fulfilling our study criteria, so those running for the first time and being young runners aged 18 to 35 who develop more plasticity and essentially have more trainability in their hearts. About just over 10% of those were interested in getting further information and contacted our call centre, and we recruited successfully 120 of those individuals in a space of about 2.5 weeks to undergo this initial testing in October 2011. Of that cohort, we anticipated and we knew from data from Virgin Money London Marathon that approximately 20% would become injured in their training process and not be able to complete the marathon, and that was the case. Unfortunately, another 23% or so were just unable to keep appointments with us and be tested after the marathon. One we had to exclude as we discovered a new diagnosis of a long QT syndrome. So the data I'm going to present to you is focused on these 68 who managed to run the marathon and attended for their follow-up testing. So what did this group look like? Well, on average, the age was 30 years of age. We had a slight male preponderance, but when we look at other studies, longitudinal studies of exercise-induced cardiac remodeling, we had good female representation, which is not typical of many studies. It was heavily a white European population who, on average, exercised for 2 hours per week. So these are not completely sedentary individuals, but neither are they ready for running a marathon, and certainly there will be a significant amount of training involved. In terms of weight, percentage body fat, resting heart rate, blood pressure, and peak oxygen consumption as assessed by cardiopulmonary exercise test, you would be in good company and forgiven for thinking that these should change after one prepares for and runs a marathon. But the small changes we did notice did not reach statistical significance. That was a little surprise to us in some respect. But then we have to consider about the performance of these individuals. And everyone runs at their own pace, and everyone invests slightly differently in the amount of training that they'll do. Apologies, Dr. Malhotra. So we found to our surprise that just over a third of individuals actually had a lower peak VO2 value, or they had a drop in their percentage predicted peak VO2 values from the baseline to following the marathon. A large proportion, over a third, actually had almost no change, if not very small increments in their peak VO2, and less than a third were increasing by 10 to 20% of their percentage predicted peak VO2. And in all honesty, when we designed the study, we presumed that much of the group would actually occupy the last. When we think about how they performed and how they ran the marathon, one individual managed to do very well and run a sub 3 hour time. Most of those achieving times between 3 and 4 hours were males, and they were in the minority. And certainly the average running time in this first time running young marathon population was between 4 and 5 hours. Men had an average running finishing time of 4 hours, 14 minutes, 30 seconds, and women 4 hours, 43 minutes and 40 seconds. And that actually falls in quite nicely with the data that comes on average race times in the London Marathon for all comers. So that's all ages, and whether you're running it for the first time or whether you're coming back to it. Looking at our primary endpoint of left ventricular trabeculation, so our original study model, it really didn't matter whether you were looking at Chin criteria, Jenny criteria, Peterson's criteria, Shakir's criteria, or looking at fractal dimensions. It was very difficult to show any meaningful change. And even where there are statistically significant changes, the Chin criteria actually shows a slight, microscopic almost, increase in trabeculation, whilst Peterson's criteria actually shows a drop. And showing here some MRI images of my study participant 12. This is at baseline on the left and post-marathon on the right, and you can see it would be quite a difficult job to call a difference between those two studies. So I'm telling you what didn't change, quite surprisingly in some respects, but let me now tell you and move on to what did change between October and May in these individuals running their first marathon. Well, we did see a statistically significant rise in indexed left ventricular end diastolic volume of 4.1%, a rise of right ventricular end diastolic volume of 4.9%, a rise in LV mass of 5.5%, and a smaller increase in LV wall thickness of 2.2%. And actually, when we look at where the reference limit cutoffs are using cardiac MRI, and one can criticize the reference limits and say that perhaps they don't include a broad enough population, but these are the ones that are quoted on most MRI reports and available on most software. We can see at baseline that a small proportion of individuals did commence the study with indices of left ventricular dilatation, so above the normal range for left ventricular end diastolic volume and right ventricular end diastolic volume. But those that then crossed the threshold and post-marathon demonstrated left ventricular dilatation or right ventricular dilatation increased, and significantly so with respect to left ventricular dilatation. Those with hypertrophy essentially didn't change. What was also reassuring to note in this young population is that there was no study either at baseline or post-marathon that demonstrated any late gadolinium enhancement or fibrosis. And something that may interest Professor Borgesson as well is looking at the differences between men and women. So again, these are indexed values, and both have relatively similar increases in both indexed left ventricular end diastolic volume, right ventricular end diastolic volume, and mass. But when we look again at those who cross a threshold according to the upper limit of the reference ranges, again we see far more men, and certainly in terms of left ventricular dilatation, who cross a threshold with this small increase in cavity dimensions compared to women who, though those increases are present, tend to maintain within the normal reference ranges. So the messages I'd like you to take home from my talk is that rather than describe individuals as being appropriate for having an athlete's heart or not being athletes, it's best to consider athleticism as a continuum, that modest amounts of exercise will produce modest changes, and certainly training for a single marathon run is a model that produces modest cardiovascular remodeling changes. Something perhaps we'll talk about in the questions is there is actually little strong evidence to support clinically important cardiac injury in normal hearts in running a marathon, certainly a first marathon or only one marathon. And 20% of novice marathon runners will exceed upper reference limit for biventricular dilatation. So if in your clinical practice you encounter someone who's recently run a marathon, consider that 1 in 5 you might see that the indices are above what is set as normal ranges. This was a very challenging study to pull off, and I'm extremely grateful to the sponsors, my supervisor, our collaborators at Bart's Heart Centre. There was an immense team required who gave up their weekends in order to perform the study, and this could not have been done without the support of cardiac risk in the young, which was not only financial, but in terms of personnel, transport, and infrastructure.